In a country as vast and diverse as India, true progress means making quality healthcare not just a privilege for a few, but also a right for all. From villages to slums, there are people in the country who still struggle to access affordable healthcare, but change is underway, and we have change makers here with us, with government schemes, innovations, and low-cost delivery and community health workers leading the charge. Today, we look at how India is working to ensure that healthcare reaches the last mile and leaves no one behind. We have with us Dr. Matthew Varghese, who is orthopedic surgeon, also known as the Polio Man of India, and we have Dr. Indu Bhushan, CEO of Ayushman Bharat, and we have Dr. Reggie George of the Tribal Health Initiative, and we have Mr. Ankur Bharti, Executive Director, Grant Thornton, India. Thank you so much, all of you, for being here. I start with you, Dr. Matthew. 2011 was the last year when polio was registered. A case of polio came in India. That was probably the last year. But for people who have polio, this is for a lifetime. As somebody who has spent a lifetime in public health, how do you look at public-private partnerships? Also, when it comes to dealing with crises such as polio, what are the lessons that India needs to learn?
Thank you. Thank you for the opportunity. The lessons from polio are many. Preventing a disease like polio is a life-changing experience for the family, for the community, for the village, for everyone. So once you're able to prevent it, there are those that were paralyzed, they are still there. So people ask me, do you still see polio? Yes, of course I see polio. Only difference is, when my ward had boys and girls in the same ward, reserved beds, they were taken care of. Today, there's a separate ward for men and there's a separate ward for women because they have grown older. So the only thing is, the difference is, there is older polio patients which handling becomes more challenging. For me as an orthopedic surgeon, correcting deformities in a child is easier. Correcting deformities in the older patient is far more difficult, far more challenging, which means to get access to this facility where care is being given, so the number of experts are gone down. So how many people can deal with an older polio patient? That's also gone down significantly. So there is a need to continue your expertise in this area and at the same time to make it affordable in terms of access.
Right.
A lot of patients come to me when I talk to them, "Kahan se aaye hain? Where have you come from?" Distances are not measured in kilometers. Distances are not measured in hours of journey. The lady tells me, 500 रुपए दूरी से आए हैं डॉक्टर साहब, 500 रुपए दूरी से. There is no mechanism by which this 500 रुपए दूरी for a polio patient means the mother, right, the father, the polio patient, and maybe somebody else who can access the healthcare system better than what the illiterate person can handle. So that 500 रुपए दूरी is 2000 rupees for 4 people to come to the city of Delhi, live in the city of Delhi without anybody known to them, and eat food from the dhaba outside. When Dr. Balu Shankaran started the polio ward in my hospital, and when he started the polio ward in the hospital, we used to have all hospitals provide food only for the attendant.
Right.
Only for the patient, not for the attendant. So I realized it very soon, the mother would not get food from there. She shares the food from the patient. So I realized we must provide food for them. But there was no policy on it. I had to convince the management on this, that you have to provide food for the attendant also. Otherwise, what happened, one day I found mother was lying on the floor adjacent to the bed. Why is she lying on the floor? Doctor sahab, wo bahar kha liya tha humne, dast lag gaye. So here is something which we don't think of. No insurance provides for this travel expense. No insurance provides for the caregiver who is caring for the disabled. There is no insurance for that. There is no support for that. No corporate sector, no CSR funding cares for this.
Right.
How do you bridge this gap? That's a challenge.
That's
I'm
a
also
very
finding a
important
challenge.
Yeah, Dr. George, I was looking at you have a wonderful story, and we need to talk about it. You and your wife decided to be in a place where there were very few doctors. In fact, I remember Lalita ma'am's words that I don't want to be the 11th doctor in a place where there are already 10 doctors. You wanted to be doctors in a place where there are none, and you operate out of a very small village in Tamil Nadu, in Dharmapuri. What does public health mean for you? Because you have served the tribal community, one of the most deprived communities of the country, for a long time. When we talk about affordability access, what does that mean for you? Because you have been serving the most marginalized sections.
Yeah, thank you. Vanakkam. Yeah. Now, public health interventions, 30 years back, and public health interventions now have changed a lot. Because the health situation in the country has changed for the better. So we went to Sitlingi when the infant mortality there was 147 over 1,000. It's now 8. So now our public health interventions definitely has changed over the years. The government has come in a very big way, But the tribals of Sitlingi and the Kalrayan Hills are fortunate that we are there, because the elephant that is never recognized in the room is secondary healthcare. And we have graduated from primary healthcare to secondary healthcare, meaning that we are now not in the tertiary space where you are looking at, neurosurgery or cardiothoracic surgery. We're not in the primary care space, because I think the government has done a fairly good job all over India in terms of maternal mortality, in terms of infant mortality, in terms of malnutrition. But nobody is talking about secondary health care. If I have a hernia, where do I get it operated? If I have an appendicitis, where do I go? If I have a ruptured ectopic, where do I go? Now this whole space, this whole plethora of diseases is now going to the private sector. Because the government's budgeting and policies are now aimed at primary and tertiary healthcare, where they have done a wonderful job, no doubt about it. But nobody is talking about this. And so now we are a surgical care facility, so we have a lot of cases coming. But like I said, they're fortunate that we are there. Why isn't the government now talking? And if we are talking about 2047, we should build up these facilities in the government hospitals. See, our taluk hospitals, our, even some of our bigger PHCs should have surgeons, should have anesthetists who can deal with these things. And that makes access to these very important. I think that is one thing that we should start talking about. Nobody is talking about
Absolutely.
it, except people who are working in the grassroots.
Very, very important point. Dr. Indubhushan, I remember when Ayushman Bharat was announced in the budget, we all thought that was a big shift, India becoming a welfare state. And there was a lot of criticism. A lot of people felt that this was just not possible. But now we see Ayushman Bharat expanding. Now, elders, senior citizens above the age of, 70, 80 getting covered. Insurance is also growing. States are coming up with their own models. Objectively, how do you assess the way the scheme has worked, and what has it done for the poor people of the country when it comes to health concerns?
Well, very important question. In 2018, when Government of India and Prime Minister Modi started this scheme, the situation was like this, that if the majority of expenditure on health was out of pocket. So for poor people, if they get sick and they have to go to the hospital, either they had a choice of foregoing the treatment because they can't afford it, or borrow heavily, or sell their assets. And there were studies to show that millions of families were either becoming poor or becoming more poor because of expenditure on health. And so Mr. Modi decided that that is not acceptable, and no one should forego treatment only because they can't afford it, or they should not become poor. And it was a massive scheme covering more than about 40% of the country, more than close to about 50 crore people. And so started in 2018, as the minister was saying, that so far close to about 10 crore treatment has been provided. And if you look at what is happening now, the scheme has become very mature. And every month, 25 lakh treatment, and every year about close to 3 crore treatments are being provided. And obviously, it's a big change. And now there are a lot of studies. It has spawned so many studies, so many PhDs have been done on this scheme, and all of them very clearly show that, of course, things need to improve, but in terms of impact, there has been a real impact. Right. The out-of-pocket expenditure, which used to be about 65%, it has come down to about 38%, half. And in terms of cancer patients, people who are covered by health insurance or from PMJ, they're seeking treatment within 30 days. And similarly, number of people who are getting impoverished almost has vanished. So this scheme, in terms of changing the paradigm, because earlier the paradigm was that we build hospitals, we'll provide services, and people will come and take them. The scheme was that, of course, we'll do that, but at the same time, we'll support people from demand side. When they use services, then the money will flow, and we'll get private sector into the system, because as you were saying, that most of the tertiary care is provided by the private sector, and earlier the poor people, 40%, 50% of those were totally out of the ambit of those services. Now they can go and use those services. So huge impact, I would say, of the scheme in terms of it's a leap towards the universal health coverage. It has made services affordable for most Indians.
Well, many people say that the fall from a middle-class family to a BPL is often just one illness in the family, and which is what Ayushman Bharat has also managed to address. Mr. Bharti, when it comes to financing, when we talk about health insurance, specifically for senior citizens, they say that, claims बहुत ज़्यादा होते हैं. There are many young people are okay, in insuring their health, and also companies are okay funding them, financing them. But when it comes to senior citizens, how is the public-private partnership working when it comes to medical insurance?
Sure. See, Dr. Indubhushan being besides me, I'm not the authority on insurance, but let me try and attempt this. What is happening, and that might not be a great thing about our country, which is happening is not a great thing, which should be eventually for our country, is that health premium for especially senior citizens, private health premiums are increasing exponentially, right? Even corporates are facing the same problem. Their own premiums for the employees' parents have increased, have become 1.5 times this year, I can tell you, right? So that is something which has to be looked at. There would be a time when it would become unaffordable for senior citizens to get health insurance because of the premium rise. We, not so young, but till our age, it is still fine. The policy premiums are still affordable. But once we cross 60, it becomes unaffordable. And every year it is increasing by up to 50% for senior citizens. So that is a very critical juncture we have reached in. But then insurance companies has to make profit. They can't keep on incurring loss on their health insurance portfolio. That's very important. So where this public-private partnership is working and tremendously working is that with the launch of a senior citizen health policy, government senior citizen health policy, there would be a parity which would be reached between private health insurance and public health insurance. My dad, who is a doctor, he has registered for this insurance, the public health. He is 72 now, and he has registered, right? He has a health insurance of his own from private player also. But then the way premiums are going up, probably there would be a time when most of the senior citizen would not be able to afford. That's where this government policy would be very important and would be critical for this sector, right? Another thing which I wanted to add, and this would answer your question even better, is that the health system of our country, so to say, I keep on telling, is one of the best across globe, not just because I'm an Indian, but it is structured in such a way. So I keep on calling it, and lately, it is a trinity of three things. Layered public health system, which is primary, secondary, tertiary, same layered private health system, But then one additional thing which has come into picture is medical colleges, which have been there for last 10 to 15 years. The sheer number of medical colleges being opened every year. Now, medical colleges in India are in a very different structure. They require large hospitals to be opened up. Fortunately, most of these hospitals, because of their location in rural areas, they are still providing only secondary care, Dr. George was talking about. So most of the medical colleges, both in public and private, which are located in rural area, are only providing up to secondary care. They have not reached the tertiary care level. So that is also creating a layer, and the cost of treatment in even private medical colleges is still much lower than other corporate and private health systems. So given the public health insurance for senior citizen, the private health insurance for senior citizen, who can go into corporate hospitals, and the medical colleges, which the pricing is so low.
Right.
You have an umbrella which covers almost all the citizens.
That's very interesting. Dr. Varghese, one interesting part of your journey is that when you started working on polio, I remember that, I've read upon how you used to have these door-to-door campaigns where you would ask people questions on their social class. A lot of diseases that Indian society has is a product of not just lifestyle, but the social class that we come from, the kind of nutrition we have, the kind of resources we have. When it comes to polio specifically, what was your learning? Because I see you not just as a doctor, but also as somebody who understands society. How was that learning very important for you? And how is the understanding of the community very important when you understand public health?
Yeah, I did a house-to-house survey on disability in 9 villages in the Sonipat district. And I used to go there every weekend. Saturday was spent there with a colleague of mine from IIT Delhi. We would do there doing a disability work. That was eye-opener for me. I realized that these families, they were not extremely poor. And when you read the literature, it's very clear. Extreme poverty, the infant mortality rate is very high. Children do not survive past the mother's breastfeeding era. And once they survive that breastfeeding period where they get protection from their mother's milk for the antibodies that are there, once they start crawling, they get paralyzed. And once they are paralyzed, they are crawling on the ground. And I realized soon the impact it has on their life and in the family's life. The child would be educated to the level of the school available in that school village. So if it is till the 5th class, the child will be educated till 5th class in that particular village. The other village had a higher secondary school till 10th, secondary school till 10th class. The child will be educated till 10th class. And the child will be educated till 12th in the village based on the transport that is possible. So there's a wheelchair. The villages' roads are not wheelchair accessible. So how do you get them to have, those are learnings which I realized. And when I looked at the educational status, each of these children were 2 grades below their level expected. 2 grades below. And education only to the level of the school in that village. So access is a huge issue for the disabled in rural sector. And this was the learning I had from that village study that I did. That's a published paper, actually.
Right. Dr. George, similar question to you. So you and your wife also work on building communities. You help them not just grow turmeric, but also, ensure that they promote them in ways that is best for their own livelihoods. How important is it to have a very community-centric approach when it comes to public health, specifically in communities like the one that you work in?
So, I first worked in a Gandhian institution. So, the whole thing about Gram Swaraj is very important to me. How can communities look after themselves? And so when we started working with tribal women trained, just like our Asha workers now, but they were illiterate, to start looking at their health. And then we realized that health encompasses so many things. It depends on the food we eat, the money we have in our pocket, the roads you have, the water, whether is it available or not, soil fertility. And then as clinicians, we were flummoxed. We didn't know what to do with all this. So we went back to the community and we sat down with them. And they said that our biggest problem is farming. Our biggest problem is not health. Our biggest problem is farming because farming is a loss.
Yeah.
And we said, okay, I don't know anything about farming, but one of the things I know is that from what I have learned, we should make profits without hurting others, and therefore the only alternative is organic farming. And so we started with organic farming, though many of them didn't believe, but it slowly built up. And farming is something which every tribal can relate to because they do it every day. And therefore, we already had this credibility as doctors and also this farming thing. And one thing led to the other. Farming led to livelihoods, livelihoods led to craft development led to water conservation, led to governance. Actually, the tribals of that area have elected the Panchayat president. She's one of our senior nurses, who is non-political, saying that we want one of us to make the decisions on what our community is, not any political party. And that was a learning for us. Over 30 years, how health becomes dependent on so many things, and how communities can actually take things into their hands. They only need this catalyst, like people like us, behind them to do this.
Absolutely.
And if infant mortality, we have not had maternal mortality for the past 15 years. And infant mortality is now much below national average. Now that is possible only with community engagement.
Right.
It is not, you cannot run a hospital and get that.
Absolutely. Dr. Indubhushan, Ayushman Bharat was also very unique because it was partnership, not just with the states, but also with private healthcare, private hospitals. Do you have any complaints with private hospitals? How are they dealing with this? Because Ayushman Bharat concerns the poorest of poor. And private healthcare, but the model itself is in some ways health-driven, but also profit-driven. Did the government, did you face any challenges convincing the private agencies in this regard?
So you're absolutely right. One of the key features of the Ayushman Bharat was that it's first time ever that government was co-opting the private sector in the government scheme, where we were asking private sector to join hands in providing these services. And if you look at it right now, about 80% of the tertiary care under Ayushman Bharat is being provided by the private sector. And of course, of the about 30,000 hospitals which are impaneled, about 40% are from the private sector. And so private sector is playing extremely important role right now in providing services. And you're right that, private sector initially was slightly hesitant in coming on board because the rates which were being offered were not very high. I would say they were viable, but they were not maybe as high as private sector is used to charging. And we were trying to convince them that instead of having high margin and low volume, you should be looking at low margin, high volume. We'll give you a large number of patients. And so private sector actually told us that, we are okay with the prices so long as you can assure us that our payment is done on time, because their experience of working with other schemes like CGHS was not very positive. And we made it, we actually focused on that the payment should be done on time, because, if we have to have partnership with private sector, we want to make sure that there is something in them, for something in it for them. Otherwise, why would they be participating it? But in mostly, I think, over time, we also have revised rates. In some cases, we've increased rates. In some cases, we thought rates were actually too high, we reduced it. So that process is still going on. And I'm sure that it's still only 7 years, and 7 years is not a long time in a life of a scheme. Over next few years, probably that kind of equilibrium will come, where it will be a win-win situation, where private sector will also see a benefit in joining the scheme, and government, of course, is very warmly welcoming private sector's participation.
Absolutely. That's something that we all hope for. Mr. Bharti, when it comes to financing, when it comes to health insurance, I see that some states do very well, some states don't do very well. There are states like Madhya Pradesh which seem to be doing well, but Kerala seem to be... So what happens in that regard? Is it the demography that matters here, the kind of people, is it the mindset, or is it just the kind of diseases that impact one state and not the other?
It's also about maturity of health system altogether. At places in states where the health systems are not as mature, people tend to find solutions in other things. You named Kerala, the health system is very mature, especially the primary and secondary health system is highly matured. So people don't see that, insurance would help them much because public health system provides you such great health facility for free. So why to, go for insurance or any other kind of cover? But then states in which the health system is still struggling, and though they are improving tremendously, I can tell you Bihar, UP, I have seen Bihar, Odisha, West Bengal, they have been doing very well now. They are trying hard to reach to other states level. But then since the public health system hasn't matured enough, people try to find solace into other schemes which can provide them that kind of support. I mean, the sheer number of patients who come to Delhi for treatment, both in public and private hospitals, they need some kind of umbrella cover to take that up. So you'll find these things there. And then also there is another component which might not be that important from public health point of view. But then presence of corporates, industries, is another, because they are one of the largest consumers of private health insurance from a group insurance point of view. So you'll find that the largest number of insurance policies sold is in Bombay, right? Across India is in Bombay. Why? Because 40% of your economy runs out of Bombay, and head office of most of the corporates is based out of Bombay. So all the policies are given out of Bombay, right? Mumbai. So that's another reason why you see parity in health insurance distribution across the country.
Right. Mr. Varghese, I know that you've worked in Delhi. While we talk about rural public healthcare and urban healthcare, there's a large portion of urban poor now, specifically in mega cities. How do you look at an affordable public healthcare system for the urban poor who are living in mega cities? And there are estimates that India will be urbanized more and more in the coming years. Do you have a model in your mind that should work very well, specifically when it comes to the poorest of poor people living in cities of the country?
Yes, indeed. It is a challenge because once the infant mortality rate goes down, then those children that survive, they will eventually need secondary, and eventually when they reach 70, they will need quaternary care also. Maybe a stroke, maybe cancer, maybe cardiac. Because eventually as a person grows older, he will need high-end care, will need arthroplasties also. So those are challenges. But the challenge there is, do we have to keep it healthcare as a profit-based or healthcare as an altruistic model? So the moment you bring healthcare as a profit-based model, then the biggest casualty that can come in, to my understanding, is ethics. Ethics. So can we provide ethical care from the private sector as well as from the government sector? So a lot of patients come to me asking for, Dr. Saab, do I need to have this surgery? Just a double check, is it really required? So that kind of a model of ethical care, whether the trust between the doctor and the patient becomes important, is a critical area. So therefore, patients are worried about whether this particular surgery is for profit or is it really indicated. Okay. So hospitals like mine, St. Stephen's Hospital, or for example, other hospitals that are there, which are working on this model where the patient is not viewed as a client to make more revenue, but patient is viewed as a person for whom service is provided for. So my hospital, 70% of the beds are general and 30% are private, and we do not have any profit being driven back to anybody else not to the shareholders, not to the doctors. We are all on salaries, and that's a model which is workable. As director of the hospital, I could run any number of free patients, any number of those patients were taken care of without worrying. So subsidized care for the poor could come from the care in the same hospital from the wealthy patients that are coming and accessing very high-end care.
Okay.
So both are required. You need to develop the tertiary and quaternary care and high-end care to the rich being provided for while they subsidize for the care of the poor. It is a doable example.
Okay,
But you need to look at, are we willing to do that or not?
Okay, Dr. Indubhushan, do you have any comments on that? Because you must have seen how states are looking at this balancing act between low-cost health models and also high-end models. Do you think subsidized healthcare also works with private healthcare also, which is profit-driven? Is it workable according to you?
Of course it is. We even in the private sector, we've seen that I don't want to take the name, but Narayana, they provide high quality tertiary level care at low price. And there are some other hospital chains, again, I don't want to take the names, who have done that. But my own sense is, now two things are going to help in terms of reducing the cost. One is technology and AI. And Minister mentioned about telemedicine. It will not be possible for very highly specialized doctors to be present in every village. And they will be there in certain geographical areas. Right now, most of them are in metropolitan cities, but maybe hopefully they'll be in smaller cities as well, but they'll not be in villages. So how to provide those kind of services to the poor who are living in villages? I think telemedicine is going to help, but also AI is going to help. Yesterday, I was in a conference where they were presenting an AI model for oral health where you just take a scan of your mouth and it can tell you if you have any major problems with the teeth or oral cancer and many other things. And so this can be very easily done by ASHA workers and others. And so this AI model can also help in terms of screening large number of people and identifying people who need support, and they can be provided that support using, say, Ayushman Bharat or other things. So I think that is the way to go in terms of through technology, reducing cost and making it more affordable.
So a tech-driven approach can work in the benefit of India's public health. Thank you all of you for joining me on this panel. The journey to universal healthcare is long but also important. With stronger systems, empowered frontline workers, inclusive policies and collaborative innovation, India is surely building a healthcare system that works for everyone, because healthcare isn't just service, it's also a promise that needs to reach every home. Thank you so much.